All right. Good evening, everyone. Happy Tuesday, February 10th. You are here again in the CSOMA community we're here hosting our second Tuesday of the month webinar series. This is going to happen all year long, that you can tune in on Tuesday nights to just join this community, to go deeper in our knowledge, to relish in this beautiful medicine, to hear new ideas, and to really be with each other on a consistent basis to continue to strengthen our community. There's a lot happening at the state level, at the national level, that is making education and integrative medicine perhaps more challenging to deliver. So, more than ever, we need to come together, deepen our knowledge, advance our practices, and build our community. That's what we're here to do tonight. I'm Ra Adcock. I'm the executive director of CSOMA. Put in the chat where you're tuning in from. We want to know where are you right now? Where are you joining from? Is the chat open? It is. Yeah, it's open. Great. So go ahead and put in the chat where you're joining from. And I'm going to just do a quick announcement, and we're going to get on with an amazing program tonight. I'm going to screen share just for a second. I want to make sure that everyone here is also tuning in to the CSOMA website. Kim Newman, our communications director, has been reworking our website. There's a lot of new and amazing things. So keep tuning in, because there'll be more and more member benefits that are going to be really easy to see and claim, and all these amazing opportunities for learning and to stay informed. So first of all, csomaonline.org is where you can find all the good stuff happening. Make sure you sign up for our newsletter. And that is, where do I find that? Quick. So here, join CSOMA, sign in. You can sign in there. You can find our newsletter here. Make sure you're getting that every Saturday with a couple of extras here and there. Look at these four. It happens to be all men this time. Sometimes it's not, but it just so slotted this way. These are the first four webinars of 2026. We are right here at February 10th with Dr. Magarelli. And next month on March 10th, we'll have James Frame giving you some key tax pointers. He has so much information. You don't know you need him until you go to his lecture and realize how much he can save you in money and being strategic about your finances. And then in April, we have Dr. Waito, who will be looking an osteopathic physician from Florida, who will be talking with us about digestive and metabolic disorders. Every second Tuesday of this year, you will be able to join this. Now, if you need CEUs, we ask you to throw a little money this way to support this program. But if you don't have that, or you don't need the CEUs, we don't want you left out. So you can always join this program as an observer for free. We have an abundance mentality at CSOMA. Let it overflow for everyone. So other upcoming events that I want to orient you to: May 1st and 2nd, we will be having a live conference in person in Los Angeles at the gorgeous Yosan University campus. So that's a Friday and Saturday. We have a great program. We're about to launch registration for that. So do sign up for that if you're in Southern California. We have a really fun conference. We have a great time. A lot of vendors, prizes. We do this big, like, Price is Right raffle every day. It's so much fun. My favorite part. And then if you're in Northern California, you just hold your horses and wait till September, and we will be having an event for you too in Oakland at the California Endowment Center in Oakland. And that is happening September
24 and 25.
24 and 25, and that's a Thursday and Friday. So LA's Friday, Saturday, and in May, and then Thursday, Friday in September. Make sure you join us for those. Okay, we're going to be having a couple other events to pop in. We're going to just this morning, the CSOMA board meets every Tuesday morning, and we've decided to have a State of the Union town hall to talk about all the changes with education, student loans. I'm sure you're hearing a lot of things out there. We want you all in the know. So we're going to be putting that event up soon. That will happen sometime in mid-May, and that will be online. So stay tuned for that so that you can hear the what's up about the acupuncture profession and how we're going to continue to navigate this no matter what challenges are put before us. This medicine's 2,000 years old. It's got at least another 2,000 plus years to go. So these little speed bumps are going to set us back a little bit, but probably project us into an even more creative version of our profession. So tune in for that in May. All right, I'm going to stop sharing. Make sure you check out the CSOMA website. I'll stop sharing there. And I'm going to turn it over to one of our amazing board members, Dr. Rob Hoffman, who is also the president and CEO of Yosan University, doing amazing things there. And he's got a few things to talk to you about before we start our program.
I will promise to be quick, and I won't. I don't think I can follow Ra. That was like so big and so like amazing. But I'm really excited to be a part of CSOMA and to be on the board. So I get to meet with Ra and Julie and our other board members every almost every Tuesday morning, and Kim drops in when she's available as well. So when we came up with this idea of these kind of monthly topics, it just made sense to me to get Dr. Magarelli here. He's a huge proponent of our profession, of Chinese medicine in general, and he's just been a great friend and mentor to Yosan University and to me individually. So, of course, there's a little tie-in. We have a annual reproductive medicine symposium that's coming up, and Dr. Magarelli speaks at that every year. This year it's March 7th and 8th, and once we get going, I'll go ahead and put a link to it in the chat. It's a hybrid event, so if you're local or feel like having a weekend in Los Angeles, you should definitely come do it. It's super fun. We have a ton of sponsors. We usually have about 100 people on campus and another 100 to 150 online, so it's a pretty good size event. It's a good event. And if you really love Dr. Magarelli, our DAOM program is the best reproductive medicine specialty in the country. And Dr. Magarelli teaches, I think, 3 classes in that right now. So we get a lot of Dr. Mag. And again, he's such a huge proponent of what we do. So Reproductive Medicine Symposium, DAOM, all at Yosan. And you know what? I was just thinking, Ra, if they came to the Reproductive Medicine Symposium, came to the Yosan conference, and came to the Bay Area conference, that would be almost all of your CEUs in 1 year just by coming to these 3 very affordable, amazing conferences. So, just thinking ahead for your CEU needs. I think maybe you'd need 1 or 2 of these online conferences and you'd be done. So there would be an opportunity to hang out with all of us in those 3 conferences. Let me move on to Dr. Magarelli. Like I said, I will put a link for the reproductive symposium, either in the Q&A or chat, whichever I have access to. We'll see as we go. I was very lucky in my first really couple months of becoming the dean of the doctoral program at Yosan. Everybody kept telling me, you got to meet this guy, Paul Magarelli. And, I'm like, okay, sure. And then I found him, or he found me in Vancouver at another conference, and he said, everybody told me I need to meet you, so I'm here to meet you. And we've been incredible friends ever since. We call each other like teenage kids, like in the morning on the way to work. What's going on? What's happening with you? I'm freaking out. We totally support each other in all of our healthcare needs, our relationship needs, our educational needs, our professional
Wait,
needs.
my friend. I thought this was a professional intro.
Well, I'm getting to that. But what brought Dr. Magarelli to Yosan was his actual creation of the reproductive medicine specialty and his creation of ABORM, the Association or American Board of Oriental Reproductive Medicine Practitioners. So he comes to us. He actually has a PhD and an MD, which is not that's a pretty rare thing. And his specialty in his medical practice is, of course, reproductive endocrinology. He did his residency and fellowship at UCLA, at Cedars-Sinai, at Duke. I mean, he's published. He's the all-around MD, and like I said, he's a friend to our profession. So he's truly an ally. And I always learn something, even when we're just hanging out casually and socially, as well as when I sit in his classes. I think I've probably taken your classes 4 or 5 times at this point. So,
Hopefully you learn stuff.
no, I do. and I think that's all I need to say. So I'll turn it over to Dr. Magarelli.
Well, wow. I'm flabbergasted with the introduction. I am very honored to be here at CSOMA. And it's new for me, this group. I love teaching. So during this discussion or sharing of my thoughts about integrating Western medicine and traditional Chinese medicine, please throw questions in the chat. You're not going to interrupt. I mean, if even Ra's going to monitor the chat, She's absolutely welcome. The more discussion we have, probably the better. It's never easy to talk about anything in 2 hours. And when you do, you have to understand that it's usually 10,000 foot, then 1,000 foot, then 10 feet, but then jumps back to 10,000 foot view, so that the story that I want to talk about is the story of my medicine and my thoughts about your medicine, and then hopefully bring it together to some actionable items that you can do with your Western colleagues. And because that's what it's all about. I mean, my biggest joy are my friends in traditional Chinese medicine. They are deep, deep friendships and very meaningful friendships. And so reach out to them. Okay, too much talk here. Okay, now I have to take over sharing here, so just give me a moment so I ensure that I share correctly here. And I don't see that option. Why don't I see that option? Oh, there it is down here. Okay.
Right.
Um,
I got your back if you need anything, Paul. Dr. Magarelli.
okay, no, thank you. Let's see, application, share, and then you tell me if that looks like you guys have seen this. Does it look like the way it's supposed to look?
It's loading. There it is.
There it is. It looks
Okay,
great. And Dr. Magarelli, I'll check the chat and the Q&A for you.
thank you.
Please do make this an interactive night, everyone. And we'll probably have a bio break sometime in the 8 to 8:15 range, whenever Dr. Magarelli thinks it's a good moment.
Well, right now for me it's 8:13, so we'll have a break in 2 minutes. Just kidding. No, it's a different time zone. All right. Let's see if I there we go. This is welcome, of course. We're going to talk about Western medicine and traditional Chinese medicine, and I'm just going to share. I mean, basically, it's an opportunity to share with you. As Robert mentioned, we have our Integrative Reproductive Medicine Symposium. This year, I don't know, I think Robert will agree, we have even more allopathic physicians than I think ever that are joining us who are passionate about bringing and bridging our fertility practices and around the area of reproductive medicine and fertility. So let's just talk about, I'm not assuming anyone is an expert here in fertility, so I'm going to give some general concepts just to understand. There's about 10 to 15% of couples worldwide who are defined as infertile, and the way most countries will define it is unprotected intercourse for 1 year. We expect 85% of most couples to be able to impregnate their partner or get pregnant. Of course, we're talking heterosexual couples, and I'll pretty much be defining that in this lecture because it's a very large population that we manage. And so that's where that 10 to 15% will not be able to achieve a pregnancy within the first 12 months. If the woman is over 35 years of age, then that number is larger, and it's the time they only give that woman 6 months to achieve a pregnancy, or that couple, because of factors that we're going to be talking about in the little section on the physiology of reproductive aging. In the United States, same, it's no different. About 12% of women between 15 and 44. So there's that magic close to 10 to 15%. But what you have to understand is most times this is a discussion of women less than 35. They're not talking about a 40, 41, 42, 43, 44-year-old woman, because in that population, let's use 20 to 30. The chance of achieving a pregnancy each month in a woman who's and where everything is healthy is about 20 to 25%. Exactly opposite to what your mom and dad told you about, if you have intercourse, you're going to get pregnant on the first try. The best a human can do in that age group is about a 20 to 25% chance of achieving a pregnancy. If she breaches 30 to about 35, that drops to about 10% per month. 35 to 38, about 8% per month. 40, about 4% per month who get pregnant, and about at 45, much less than 0.1%. So fertility is age very much tied to the female age, and we'll talk about that shortly. It doesn't matter the socioeconomic background, ethnicities, it happens to all, it happens to many. And so we really treat the global population, and it is basically a global problem. And then some of the things that we forget, and I really feel like we shouldn't, is this idea that it's common that there's emotional, financial, and certainly relationship issues that are critical to the management of infertility. These patients are hurting in many, many different forms. It attacks their sense of identity. And again, I'm talking about infertile couples who want children. You certainly can be, have a life without children, be child free, but in this context, I'm talking about those who really, really want it. So, how do we, from a female perspective and male perspective, look at the group? And again, I'm doing really big buckets here. This is not a really deep dive, but I will tell you the information should be somewhat fascinating and revealing to you. Um, we look at our field, reproductive endocrinology and infertility, is a subset. It's a subspecialty of obstetrics and gynecology, your OBGYN. So you go to medical school, you go to residency in OBGYN, and then you go to a fellowship in reproductive endocrinology and infertility. So hormones are everything. We don't deal with diabetes, we don't deal with the adrenal glands, but we really deal with the brain, the thyroid, the ovaries, the testicles. Those are pretty much. And we use hormones as a markers of what's going on, especially within the female. You'll see why that's important a little bit later. The next big question we ask to every woman, and it does, and this is critical, historically, even we were trained, oh, don't even ask the question, don't even measure ovarian reserve, and I'll tell you what that is in a second, until they're over 35. Well, that is not in any way, shape representative. Ovarian reserve is a nomenclature that describes the quantity, and it says quality here, but really the quantity of eggs that remain in the ovaries at that present moment. One of the unique things about mammalian physiology is that human females have all of their eggs present at birth. And then they just simply use them until they run out, and we call that menopause. Male, contrastly, are making sperm every heartbeat. A male will make about 1,500 sperm for every heartbeat. The quality of the sperm declines with time, but not the quantity specifically. So we look at egg reserve by measuring hormones, and then we look at sperm evaluations by doing a semen analysis, and then they have to do something. So for the female, what they have to do is they have to create, and we're going to go into details. I'm sort of, again, top-down view. I don't want you to think this is it. Top-down view, they have to create a follicle, a mature follicle every month that ovulates, and that ovulatory egg has to find the fallopian tube. It then has to meet the sperm, so the male has to ejaculate sperm outside his body. Doesn't always do that. And then it has to get through the cervix, uterus, out the fallopian tube. And in the fallopian tube is where the vast majority of fertilization occurs. So we have to understand the hormones, we have to understand the eggs and the sperm, and we have to understand the functional biology of the physiology of reproduction. Okay. As promised, we're going to look at just an idea or a pictogram of the ovary. I love this. Is one of the most gorgeous pictures I've ever found. Looking at the ovary. What I don't want you to think, this is a time-lapse photography of the ovary. These are not all happening simultaneously. So let's start right about here. That's where you have your primordial follicles. There's a certain number every woman has, she's born with, and it's a function of her maternal X chromosome and her life's experiences. Those primary follicles, each cycle, get called into action. We do not know the mechanism. And that allows a group of these follicles, believe it or not, it's 1,000 of every single month are called into action, of which one will mature into a secondary follicle and finally into a mature follicle, which will then rupture, releasing the egg. And this egg house has two roles, three roles. Of course, it holds the egg, but the granulosa cells in this follicle or egg house produce estrogen, and the stroma or cells outside of the granulosa cell or the theca cells, they produce androgens. Those androgens are converted to estrogens at the level of the granulosa cell. And so that is how a woman will have increases in estrogen during her menstruation, or menstrual cycle, not her menstruation. And you'll see the development of the lining because of the growth properties of estradiol on the lining. At a point when the follicle is large enough, which is usually about 18 millimeters in mean diameter, so if you were to measure this on an ultrasound, it creates a level of estradiol, which is 400 picograms per deciliter, that sends a signal to the pituitary to release luteinizing hormone, which causes follicle rupture. We call it ovulation. Now this beautiful estrogen-making factory now converts into a progesterone factory magically, almost overnight, over 72 hours. And basically what happens is now this ovary is now producing progestation or progesterone hormone. And that a beautiful steroid hormone at high concentrations kind of looks like fat, so it's yellow. If you've ever cut into a human body like I have, and you can see the fat is kind of yellowish, that steroidogenesis causes these yellow bodies, and that's all corpus luteum is yellow body, yellow body. Now, most of us may believe that, as this picture describes, there's follicles all over the ovary and they just grow. In actuality, it is only the thin cortex of the ovary that has the follicles. So think of the ovary as a peach, and the peach skin is where the eggs are. So the juicy part of the peach, or the stromal part of the ovary, is the juicy endocrine factory. That's where all the hormones are produced. Now, just a quick aside, some of our research on the use of acupuncture and protocols on the management of enhancement of the IVF cycle by the medications is that with acupuncture, it causes, we believe, we see neovascularization, new vessel formation, and that new vessel formation are capillaries that can reach into the cortex and therefore make available eggs that heretofore were not available. So one of the roles we see is improving blood flow to the ovary, which in turn, that's been proven. Stenova Turin did that research. Increases vascularization of the cortex, which in turn gives us access to these follicles that have been in the body since the woman was born. Well, how many? Well, here you are at birth, female. Here you are, where about 5 weeks when oogenesis begins, where that means oogenesis means the genesis of oocytes or eggs. And what you notice is that during the first 20 weeks of gestation, the female ovaries have about 7 million eggs available. Then oogenesis stops forever. So what happens is then as the fetus grows for the next 20 weeks, the number of oocytes become atretic and die. And so at birth, there's about 1 or 2 million of that 20 million available at birth in that female. And which is surprising to some, is that during birth, that little baby to puberty, that young girl is losing approximately 10,000 eggs every single month until she reaches puberty, where she's down to about 500,000 eggs. Now, this shows us a very linear loss of eggs until menopause when you have about 1,000 left. But in reality, there is a bump in the egg loss. You lose 10,000 eggs from birth to puberty. And then after puberty, you lose about 1,000 eggs a month. So every woman between the ages of 14 and 44, I'm sorry, 14 and 35, are losing approximately 1,000 eggs a month. And then at 35, there's a big dip. And that dip is what we call advanced maternal age. And that's where fertility declines very rapidly. So peak fertility is, 13 to 24, 25, dramatic drop at 35, another dramatic drop at 40. And then finally, by age 50, a woman will have maybe 1,000 or 2,000 eggs, but they're not stimulatable. So in pictograph form here, we start with about 7 million eggs before birth, lose about 600,000 eggs per month between week 20 and week 40, about 2 million eggs at birth. Then we lose about 10,000 eggs every month till puberty, got about 400,000 at puberty. And then we lose approximately 1,000 eggs per month every menstrual cycle, whether you have a period or not, literally every 28 days. So whether you're on a birth control pill and not have periods, or you have PCOS and not have periods, you're always losing approximately 1,000 eggs per month until basically menopause, when you really don't have. And what that means is that humans have only 400 opportunities in their whole lifespan in a natural cycle to achieve a pregnancy. Now, I can't see the chat, but does anybody have comments, thoughts, concerns, anything? Are we good?
So far, you're good. I don't see anything in the Q&A
Okay.
or the
All
chat.
right. So what does that mean, this loss of eggs, as it translates to the opportunity for pregnancy? As I mentioned, there is the optimal pregnancy in a human species. This is Adam and Eve, no alcohol, no tobacco, no drugs, no stress, no politics, no iPhones. I mean, just nature as its best. Fertility is around 20 to 25% at peak in a female. By 30, it's about around 15%, 35 around 8%, 40 around 3 or 4%. And as you can see, really physiologically, it's extraordinarily unlikely that a woman at age 45 will have a spontaneous pregnancy that'll go to a birth. And that's translatable by the number of eggs the woman has and how quickly she uses them. But what else happens as women age? Well, if you think of the egg as a protein fat sandwich, and it's in your you put it in your pocket today, and 20 years later you now say, "Oh, I'm hungry," and you take that protein fat sandwich out and eat it, it probably is not going to taste very good. Part of it is the denaturation of proteins, which is a big part of that gigantic egg cell compared to the sperm, which is just really a DNA transporter. So what happens is the machinery to allow a fertilized egg to divide equally, chromosomally as well as structurally, goes awry. And euploidy simply means, like, that you have the normal complement of chromosomes. For a female, it's a 45XX, and then for the male, it's a 46XX, and then for a male, it's a 46XY. And so that would be euploid. If you have extra chromosomes or not enough chromosomes or anything that would fail, usually fails, results in reproductive loss or failure, you can see that again around that 20 to 34, things are honky-dory, best a human can do. About 70% of the eggs will, or the embryos that are created will be euploid. But then as we go after age 35, you see this dramatic reduction in the proportion of chromosomally competent embryos. And they don't implant, or if they do implant, they miscarry. It is only 1 in 1,000 chromosomally abnormal embryos that survive, and typically the ones you see are Downs or trisomy 21. So one of the things we can look at are the hormones and use them to give us a indication of how many eggs you have. Now, historically, we asked the brain its opinion of what the ovaries had in terms of the number of eggs available. And the way we did that was we knew when estrogen was low, which means follicles are not producing estrogen. FSH is elevated because follicle stimulating hormone from the pituitary will wants the body to be creating follicles and maturing follicles and getting ovulated and making new babies. So the higher the FSH was, from the brain's perspective, it was working overtime to produce follicle stimulating hormone. Another measure that we can have, which I'll come into talk about a little bit later, is we now have a specific marker of viable active follicles, and it's called anti-Mullerian hormone, or AMH. So all of your fertility patients today will get an AMH, usually done on the first, second, or third day of the menstrual cycle. And it's a really good indicator of what is actively present that can grow that cycle. It doesn't tell you the quality, but it does tell you the quantitatively the ovarian reserve, and then we can relate that over time to follicular depletion. And of course, that tells us that that infertility will go up as we get fewer eggs available, as we get fewer, and those eggs themselves now get a qualitative change because of the normal aging process. So if you just look at fertility, fertility declines fairly rapidly as the female ages, and unfortunately, concurrent with that, miscarriage rate respond almost inversely. So the higher the fertility, the lower the miscarriage rate, the lower the fertility, of course. What's left you have is a much higher, up to about 90 to almost 100% miscarriage rates in women who get pregnant at about 45. Luckily, this is just an ovarian issue. The uterus could care less how old you are. Even postmenopausal uteri can be rejuvenated with estrogen and then stabilized with progestin, such that we've had pregnancies in women who are in their late 70s deliver babies using donor egg. We just rejuvenated the uterus, put a donor egg. Usually the donor is, well, most times is less than 30 years of age if they're not a family member. Fertilize the embryos with the sperm of the partners, put the embryo inside. Usually it's a mom or a grandma who offers that couple the use of her uterus, since the couple, just the biologic parents, so for some reason don't or have a problem with their uterus. And so, yes, even up to age 75, 76, we've had successful pregnancies using donated eggs. A little bit of history. I like this kind of stuff. In the 1780s, 90s, we had about 55 births, 55 women per thousand live births per thousand population, babies. At 1990, it's about 16 per thousand. By 2020, it's 10. And I just looked up recently, the most recent is 2023, so it's stabilizing at about 10 babies per thousand live births per thousand population. If you look at the rate of getting pregnant in the booming era, about 105 babies per thousand boomers. By 1990, it would drop to 70, and by 2022, it's 12 per thousand. What that means to us is we are not only not replacing through aging and death the population, but around the world, China in particular, because of their previous political policies on one baby per couple, it's devastating the world's population, the world's economy. And the biggest issues now today are not birth control, but how are we going to get people to reproduce? In Japan, they're having significant problems with even couples wanting to have intercourse. And China is paying folks huge sums of money to have more than one child or even to have a child. And this is being represented around the world. So fecundity is the ability to have a birth, and our fecundity rates are extraordinarily low in a span of about 50, 60 years. Now, part of that infertility is the age at which a woman today gets her first baby, achieves her first pregnancy that she brought to term. In 1970, the average age of a woman with their first birth was 21. In 2022, it's 30. And as you can see, once you start getting into the age of 30, it gets harder and harder to achieve a pregnancy. So the incidence of infertility is going up, not because there's new diseases, not only because there's there are diseases, but because of the starting point for most couples looking at getting their first child. So again, a little aside, this is why the new industry of egg freezing has begun to boom. I have this program called the Grandma and Grandpa's Presents for the high school student who's graduating. And the best gift is not a car, it's egg freezing and sperm freezing prior to getting the young man and young woman to college, where they're going to ruin everything with drugs, alcohol, and rock and roll, right? But it allows for the most optimal eggs to be stored. And we have the technology, we think for 100 years, or it'll last, not last, that we can keep the eggs at least 100 years. But, we can now store eggs for long lengths of time so that 20 or 25-year-old female who wants to store her eggs, when she comes at 50 to have her first child or 70, she has the reproductive potential of a 20-year-old. And that's a critical understanding. The eggs age and become aneuploid or abnormal. The uterus doesn't change. So freezing the eggs when you have the most that are normal, of course, is advantageous. People always ask why, why? Well, there are a lot of reasons why folks can be infertile, everything from disease states to military deployment becomes problematic. I worked in Colorado Springs, and we had a lot of folks who were deployed for long lengths of time. PCOS, which is a syndrome, and you guys are used to doing the differentiation of syndromes, whereas we in Western medicine talk about the differential diagnosis of disease. So again, a little aside, because I'm throwing these little integrative things in there, anything that has the word syndrome in Western medicine means we don't know what the hell it is. And since you guys deal with syndromes, you know what the hell it is. And so the combination of a Western and an allopathic and a traditional Chinese medicine attacking syndromes becomes very productive. Very productive. So what's our principles? And you can reflect on your own principles of traditional Chinese medicine, how to evaluate a couple. But what we do is we identify and correct the cause of infertility. We provide accurate information and dispel misinformation. One of the challenges, and we were just talking about this with the group before we came on from CSOMA, is language, words, ways we can talk about our two medicines that really should be able to be translated, given we're dealing with the same human organism. So you may call it Shen, I may call it something else. You may call it, spleen qi deficiency. I may call it something else, but we have to make sure that when we're educating our patients and our colleagues, that we give accurate information and not go from the colloquial. We are professionals every time we talk to somebody. Emotional support, of course, has to be built in to the process. because at every Western medicine, every aspect of what we do is invasive. It's uncomfortable, can be embarrassing, is, blood draws, ultrasounds, vaginal ultrasounds, semen analyses, ejaculating in rooms in clinics and all this other stuff. We have to be very sensitive to that. And we have to always provide more than one solution because there's usually always more than one solution. What are some of the life? This is where you guys come in, as far as I'm concerned. You spend a lot more time on lifestyle, but these are just some of the factors that have been identified to reduce fertility and fecundity. Biggest one in the country now, of course, is obesity, and if you haven't seen my lecture on the godlike protein one, the GLP-1s, it is a savior. It is a gift from God that's going to change our health and wellness as well as our fertility. And it's being used now in fertility clinics as part of their management because obesity in females causes a 10 to 13% reduction of IVF outcomes. And here's the kicker, and no one is talking about it. Obesity in the male is a 30% reduction in fertility in IVF clinics. And nobody is talking about the male weight. Again, that's something where you can get involved. Alcohol, tobacco, street drugs, different kind of solvents, herbicides, fungicides, all of these are sort of counter to fertility. Quick look, normal pregnancy should occur in a population of folks less than 35 who are healthy. Within the first 3 months, about 50% will get pregnant. By 12 months, we'll get 85% of folks will be pregnant. That's where that magic 15% of the world's population is infertile. And this is the reason we stop there, is that by 24 months, it only goes up 4 or 5%. So this loss, in that case, it's 120 let's see, 12, what is it? Yeah, 120,000, no, 12,000. 12,000 eggs, because it's 1,000 eggs per month, are lost in this period, and they may be the only viable eggs you have. So what are our indications for managing this is important. You don't have to go through hurdles to see a reproductive endocrinologist and infertility specialist. You just have to have a couple who they're trying to get pregnant and it's not working. Now, granted, there are things we do to allow them to better understand the cause, but they don't have to jump through a hurdle. If the woman is over 35, almost by definition, she's got infertility because of that description of the normal human physiology. If 3 years, no matter what, of no success and multiple partners, there's a problem. If there's irregular periods, there's a problem. Is there a history of pelvic inflammatory disease or endometriosis? These can destroy the fallopian tube. There's a problem. If there's a situation where men have had multiple partners but no success, meaning they've had unprotected intercourse with multiple partners, and you see a new couple in front of you, and the first thing in my mind in that couple is not, is it a female issue? It's a male issue. And likely it's going to be azoospermia, oligospermia, teratozospermia. Of course, by definition, if you don't have all the parts, you need help. It's not infertility, but it's inability to get pregnant because you don't have all the parts. With a lesbian couple, of course, no access to sperm. If men have inguinal hernias, this is I like little things that are red flags to me. If your couples come to you and the guy said, "Oh yeah, I had inguinal hernias as a kid and I had them repaired," he's infertile. He's going to have low T and he's going to have sperm issues. Does it mean he's not going to be able to get somebody pregnant? No, but the efficiency of getting someone pregnant is dramatically reduced. And if that woman is 35, that combination is not good. If a woman has had any kind of tubal surgery, even a tubal ligation, which, oh, I'm super fertile, I had my tubes tied. No, the mere fact of cutting the tube reduces blood flow to the ovary. And as I've mentioned before, reduction in blood flow to the ovary reduces access to eggs and reduces fertility. Of course, chemotherapy, radiation therapy, I've already talked a little bit about pelvic surgery, substance abuse, heavy smoker, and military deployment, there's a lot of Army vehicles that are utilize spent uranium to reinforce the tanks and personnel carriers against attacks by grenades or any other type of explosive device. So they're exposed to very low but real levels of radiation. So we do a history, a physical exam. I'm lying. Reproductive endocrinologists and infertility specialists. We simply they gave up on these almost 20 years ago. We rely on our gynecology brethren to do all of that. We of course take a very focused history, not the broad, tell me everything's wrong with you, but kind of focused. And then we do some screening tests. And again, most of these screening tests can be done by the gynecologist in primary care. And our industry is moving more and more towards having the nurse practitioners in our clinics do this sort of evaluation. Some of the causes for infertility, there's multiple causes, everything from genetic to age to obstruction and ovulatory cycle. This is anti-sperm antibodies is what that's trying to describe there. Any kind of pathology of the uterus. So you can see there are many, 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 many factors for the female, and that's why we concentrate on the females for the evaluation after we get a semen analysis. It's after we get a semen analysis because that's 50% of the problem. In our practice, in fertility practices, 60% of the problem is the male, 40% is the female because our OBGYN brethren can take care of some infertility issues. So there's a bias towards male factor. Again, I'll take a breath here and a sip, and then I'll speak for maybe 10 more minutes. Any questions, comments out there? I can't see you guys, so any questions or comments?
Yeah, actually, JC Davis is asking, actually, JC, are you willing to come up? It makes it way more fun because this is a really interesting question. I am gonna unmute you if you're willing to share your question in person.
Yes, can you hear me?
Yes.
I can.
I'm loving everything you're saying. And my question was, is nicotine a concern just as much as smoking? Because I have patients who will stick to nicotine lozenges and gum, but they're not smoking. What do you think of that?
I think it has a very little impact. Nicotine itself. The smoking I'm talking about is the carbon monoxide, sulfur dioxide, nitric acid, all the things that are in the smoke that certainly restrict oxygenation and lung function. Nicotine is, it's a nice little stimulant, but nah, I mean, I would, if I had my preference, live the pure life, but I don't know how many of us do that. But nicotine, I don't worry about at all. Its impact is trivial. It's
Thank
trivial.
you.
Yeah, of course. Any other questions?
Thanks, JC. I'm gonna just send you back till you have another question. Anyone else? And you don't have to come up, so don't not put a question in there because I might call on you. But it's really more fun to hear from everyone and build our community with these questions in person.
Yes. This slide, oh, by the way, your little gift at the end of this will follow up. You'll have a PDF of all of these slides to use. Would be nice if you reference me, but they're very good for education, and I hope you use them for that. And the reason I mentioned that is this particular slide, really in one place, is really nice. You can just show the couple and say, wow, overweight, underweight, excessive physical or emotional. By the way, excessive physical are marathon runners, triathletes, premier athletes. These are excessive physical stress. Now, do I say don't exercise? Absolutely not. But we have to modulate it. Without fat, you don't make hormones. So if you're underweight, your hormone production is going to be muted. For men, drug use, this is where they don't get it. Marijuana, opioids, they cause feminization of the male. You get male boobs or moobs. These men, if they're heavy marijuana users, will end up getting feminized because of how the cannabinoids work. Exposure to testosterone. Some guys who use steroids, especially in the military, to get through their lives, that will dramatically shut off sperm production. Frequent exposure of testes to high temperatures. Think of a jacuzzi and think of the testicles as a tea bag, and you're dipping the testicles in the jacuzzi, you're killing sperm. The reason the testicles are outside the body is it must be lower than the normal body temperature, or else the sperm die, or they're not developed normally, or they don't have as many, or they don't swim as well. So repeated, especially exposure to jacuzzis, are problematic. And of course, toxins, they're all over the place. And then between the two of them, for females, it's very dramatic, the loss of fertility with aging. But believe it or not, for males between the age of 20 and 40 years of age, they don't lose numerically sperm in a semen analysis, they lose functionally. The functional capacity of that sperm to do its job drops up to 50% between the ages of 20 and 40. These are little factoids, but they really help you understand what's going on. We kind of looked at this. It's just some numbers. You can look at this, but basically, aging is not good for anybody, apparently. All right.
Dr. Magarelli, there's one more
Yes.
question from Ted Ray, and I'm just going to call Ted up to ask it in person. There you go, Ted.
Okay.
You should be live now.
Yeah, I just had a quick question, wondering how difficult, invasive the process is of harvesting and freezing eggs.
Well, in an IVF cycle, basically what we do is the patient will take medications, injectable for 10 days. Then they come in, then they get another medicine that allows the follicle to mature. 36 hours to taking that last medicine, they come to a clinic. They get a vaginal ultrasound. They'll probably get 3 or 4 of them during the 10 days. They're given an anesthetic. The procedure lasts between 10 and 15 minutes. We use a vaginal ultrasound with a guide and a long needle. The needle is the same kind of needle that you use to draw blood. We place the needle through the side wall of the very strong muscular side wall of the vagina, and we aspirate. Takes us about 5 minutes each side, and that's it.
Got it. Thank you.
You're welcome. I don't know why this went crazy. I don't know why it's going back to old slides. That's very, very strange. Maybe I was hitting the wrong direction. Hang on. Probably I was hitting the wrong direction. Hang on a second. Okay, here we go. Now we're going to talk about the wonderful, magical sperm. Male factor infertility, we had talked a little bit about it. Sperm production is where it's at, but what can damage sperm production is overheating. And believe it or not, varicose veins in the testicles, they're called varicoceles, cause retention of the venous blood, which is warmer, of course, because of muscular activity, to sit and sort of incubate around the testicles, and that causes sperm's quality and quantity to reduce. Mumps orchitis, which is a just mumps disease in a teenager, can wipe out sperm, and hormonal imbalances. And unlike the female, and this is critical for you to remember for your patients, in females, we have kind of a programmed loss of the capability to produce quality eggs. With sperm, there is a thing called basal cell arrest, where on a Monday you make sperm, and on Tuesday you make zero for the rest of your life. So men who've had children with prior marriages or prior partners come back 20 years later, hey, I'm good to go, and they're ejaculating, they got all kinds of semen, they're seeing all this stuff come out, and they know this is all happening. They may not have one sperm. And you can't tell by looking at it. You have to put it under a microscope. So of course, the semen analysis will answer these things. Patients with cystic fibrosis can have congenital absence of the actual tube that connects the testicles to the seminal vesicle. Congenital absence of the vas deferens is what it's called. And that in turn can make the man sterile, but he can absolutely make a baby because today we can go directly to the testicles and take the sperm out. Still, he doesn't have any sperm in his ejaculate, but we can use that sperm from the testicles, fertilize an egg through IVF, and then we're off and running. We have a variety of sperm function tests because not only does it have to look good, it's got to be able to function. And the DNA fragmentation index is now pretty much standard. And then there's other things we can do to look at the male, like an ultrasound of the varicose of the veins, et cetera, et cetera. So it's a straightforward. Who fits the bill here? Well, it's about 2.5 million men in the United States every year are diagnosed or have infertility. What is the problem? There's either no sperm or no or erections. Now we fix the erection issue, but we have to look at the sperm issue. It could be anything from a teenager to a grandpa, and it's worldwide. It's not exclusive to industrialized areas. And we don't know actually when infertility starts in males because no country has allowed us to get prepubescent, pubescent boys and do a study to determine at what age they start producing ejaculate with sperm in it. It's like taboo. It's like, oh, we can't ask the boy, the idea is that the boys aren't doing it. And of course, we know that's not true, but we've never had a study to tell us when this is supposed to start. And I find that humorous as a biologist. And then, of course, 50% of infertility is the man. I'm going to do the T's, and then we're going to take a tea break. And I call them the 7 T's. This is what to evaluate. You evaluate for them a history or exposure to toxins. You evaluate them, this is the male, for any trauma. Many boys get kicked in the testicles and it's fine, but any boy with a history of being kicked in the testicles that went to the hospital likely is going to have fertility issues. Temperature, of course, we talked about high temperature. I call it titillations or sexually transmitted diseases because the T seems to fit. Temperance, alcohol, tobacco, drugs are gonadotoxic. Traditions, meaning their dad, their uncle, their brother have had fertility issues. Diethylstilbestrone was a problem. It was given for women in the 50s to prevent miscarriages. It caused severe anatomical problems in the female children, and now we know it also affected the boys. Now, DES is outlawed across the world, but it's historic. And then any kind of treatments in the past, like vasectomies, hernia repair, cancer, cryptorchidism means the testicles never fell, chemotherapy, etc. So those are the 7 T's. And with that, I think what I'll do is I'll stop here. Is that good for you guys? And you want to take 10? Anybody? Everybody?
Seems like a really good time to take a break.
All right, then I will take a break and I will start promptly at 9:10. Well, my time is 9:10 and your time is 8:10.
8:10. All right. We'll
All
see you
right,
back
I'll
at
see you.
8:10.
Thank you guys.
Thank you, Dr. Magarelli. I'm putting that in the chat. 8:10. Restarting. All right. See y'all back in 10.
Hello, hello, hello. Got a few minutes here. There's Robert. Hello, sir.
Hanging in. I know it's a little later for you.
Yeah, it is. I actually, you know me, once I get into a lecture, I'm jazzed. I mean, I'm good to go. I just got a text from Betsy and she said, "Are you up?" I said, "Yeah, I'm teaching for another hour." So, yeah, I said, "Don't call me. I'm going to go to bed after this."
Well, and I don't know if you saw the chat, Dr. Magarelli, but there's a lot of people going, wow, I had no idea. This is stunning. I had no idea. And actually, our team is texting each other the same thing. Like, oh my gosh, there's so much to learn. Stuff we didn't realize, you know?
Well,
So,
this is, by the way, unapologetically, that's why I said this is 10,000 foot, 1,000, 100 back to 10,000. If your doctors are going to be managing patients, the consumer knowledge is really inaccurate and problematic and is actually creates more problems than it helps. And I like this one as a intro, to but at the DAOM program and of course the ABOR, we dive very deep into pathology. But I was hoping that this would give a lot of wows, just like, oh, I didn't know that, I didn't know that.
Actually
Um,
making me excited. I was like, oh, maybe I should sign up for the fertility symposium in March.
oh, hell yeah. And this is nothing compared to the stuff. I mean, it's magical. We've got experts both sides. And they really are passionate about the language and the communication. And really, and by the way, you can still see my screen, right?
yep, your screen is still up and you might just have to click if you find it's not advancing, just click into the slide. Yeah. And
Okay.
I'm just going to put in here who in the crowd is an ABORM member because that might be really interesting to know.
Yes,
Um,
I'd love to know. I think
Thinking
I
about getting my
recognize you.
certification. I just haven't done it.
yeah, so who's
All
certified?
right.
And then Rob, I don't know if you're seeing JC's more recent comment, but any discount codes for the reproductive symposium for people attending tonight's lecture? I'll leave that to Dr. Hoffman.
Yes, but let me see if I can make it before the end of the lecture.
He'll invent it. It will
Because
be
JC,
invented.
there is a
JC
CSOMA code, isn't there?
did a solid for everyone. Yeah, I don't know if you want to put together a code. We can also share it tomorrow if you need a little more time. We can share it in the follow up with everyone. Um,
I think it's already created. Let me see if I have access to it. If
Yeah,
not,
let you guys can do that.
yep, go for it.
and I
Oh,
just,
okay.
Dr. Magarelli, one more thing. But while
Yeah,
we still have a lot of folks here,
sorry.
you will be getting, for those of you that want continuing education, make sure you look at the information that was sent to you when you signed up. That will tell you how to go ahead and take your CEU certificate for tonight's event. There will be follow-up. This is being recorded, and we can look for a possible coupon code from Dr. Hoffman for Yosan's reproductive symposium. And with that, I'd hand it back to you, Dr. Magarelli.
So first off, unapologetically, I will drown you in information, and it's all on my slides. I feel like there's not enough life in life to get all the things out that I want to educate folks about. It's my passion. And again, I'm not apologizing. I'm just saying if it seems overwhelming and a lot, it is, and that's okay because you'll have it in a format that you can go back and look at it and reflect on it and I don't know if I have it out there. You're certainly welcome to email me and preferably email me if you have questions or if you have patient fascinomas you want to talk about, and we could share that later. I am going to accelerate what I've been talking about because I've got some fun stuff. This is just, again, we're dealing with the male here. There's a physical exam, of course. There's a thing called the orchiometer, which is a thing that measures the volume of the testes compared to it looks like a string of pearls to tell you whether or not the testes is developed normally. I was mentioning about the varicoceles. That's simply varicose veins. It heats up the testicles, keeps them super warm and setting the blood circulating fast. And that again could cause problems. Um, uh, for those young men who have cryptorchidism, where the testes never fell into the sac, there's a surgical procedure to put it back in the sac where it belongs. Again, these are some questions you can ask. Do they ejaculate? Where do they ejaculate? Men can ejaculate, especially diabetics, severe neuropathies will ejaculate into their bladder, and therefore we got to get them to pee after intercourse to get their sperm. There are certain lubricants you can use that don't reduce the potency of the sperm. There's some there. Timing. How often should you have intercourse to create a family? It's intercourse twice per week, separated by 2 or 3 days. The reason we say that is you need a certain bolus of sperm and I don't know if I have that in here, but basically, most folks, when I ask them how many sperm do you need to ejaculate to make a baby, everybody holds up their one finger, one, and I say that is correct, except it's 100 million sperm need to be deposited in the fornix around the cervix for fertility to happen at the right percent of the time. So 100 million, not one, but 100 million sperm need to be deposited in the vagina, during intercourse. So a man can't produce that if he's having intercourse 5 or 6 times a day. It takes 2 or 3 days to build up a nice bolus of sperm. So, and the sperm will live up to 5 days in the female genital tract. The egg actually will live up to 2 days. So if you have intercourse over a 7-day period twice, with separating by 2 or 3 days, you never miss the window of fertilization. So none of those expensive little pee tests and running home as they show on the movies. I'm ovulating, run home. It doesn't work that way. Sperm could last 5 days, eggs can last 2 days. Mumps I talked about. All right. Can sperm vary? This is the semen analysis. What a nice guy. Over what was it, a year and a half? He gave samples, and you could see the differences in it went from infertile to fertile, etc. So men's sperm vary. There are criteria. There's actually the problem with the criteria for what is a normal count is it's constantly evolving. I'm sorry, I had to update this to 2020. I think they did another one in 2020. The numbers are very close to this number here. Again, those are easily found, but this is whose fault is it? Is it the female or the male? Oh, here's 2021. There you go. I did it. I did put it in. And you can see they really haven't changed much in terms of the variability here. This is just a measure that we use to determine if a man is normal. Why is it hard for a sperm? Because there's over 7 steps to get the sperm to fertilize an egg, and the biggest one is getting it through the wall. And so even though there's 100 million sperm ejaculated, only about 100,000 can get past the cervix. Of that 100,000 in the uterus, only about 4,000 get around the egg, and you need a minimum of 4,000 eggs and their head, which is made out of enzymes, to dissolve the zona pellucida to allow the sperm to enter and penetrate. Once one sperm gets in, this whole somewhat permeable membrane calcifies and becomes impermeable. So that reaction of the penetration creates a reaction in the zona that stops other sperm from getting in, because if you have too much DNA, the egg dies. So you just really have to get one sperm and one egg's DNA. Oops, how did I do that? That's interesting. Okay. Sperm post-coital tests are anachronistic. In the old days, the couple would have sex and run to the doctor's office, and we would do a speculum exam, look at the mucus and see if any of the sperm were alive or dead. And that was called the post-coital test. It didn't tell us anything, but we thought it did. And there's all kinds of other things. I am not going to go through this. I am not going to go through this. I am going to just move on. So These are some of the categories when we're working or working up a couple. We categorize them as male factor, ovulation factor, cervical factor, which is, yeah, we don't do it anymore, that postcoital test, uterine factor and tubal factor. And these are the various tests. And again, you have this in there. Surgery, we just don't do it. We just don't do it. Now, not for infertility. For pathology, we absolutely do surgery. This is hysteroscopy. This is laparoscopy. Those are the yin and yang of what we do as reproductive endocrinologists, and OBGYNs do it also. But we don't do surgery for infertility anymore because IVF has replaced it. A category you're going to hear your couples say they wish they sort of will always tell you, "Oh, I was told I had unexplained infertility." Um, it's it's not true. It's just they haven't been investigated enough. And I'm saying that because a lot of times when folks are told they have unexplained infertility, they think they can't have children, and that's by no way true. It's just do IVF because it's the treatment for everybody. And yes, that is controversial by you guys, not by me. It's the only treatment that really does the job. And the reason I say that, and this is a slide looking at every way, every tool in my medicine bag of creating a family. So if a couple comes in who are infertile and I do IUIs, which means putting sperm inside the uterus, I could take that 1 to 4% and make 4%. If I give fertility treatments like Clomid, I could take that 1 to 4% and get it up to maybe 5.5% per month. If I do Clomid plus IUI, I can maybe, which is now we're talking, we're getting, we're doubling. That's not unreasonable, but it's still only 8 out of every 100 couples will get pregnant. If I use injectable medicine instead of oral medicine, yeah, 6 to the 8. If I add the injectable medicines with IUIs, I can get it to now 17, 18%. Now we're getting to nature. In basic IVF about 20 years ago, it was about a 20% chance per cycle, which was considered a miracle in those patients who had zero. Then we started doing freeze-all cycles where we separate getting the eggs from putting the embryos back, and we doubled it. Then we are now able to do chromosomal testing on the placenta cells of the embryo. It's called pre-implantation genetic testing for aneuploidy. And now we're really rocking it in terms of getting outcomes that are reasonable. And then, of course, donor A, because the woman is young. So you can see that, anything below here, eh, it's a lot of money for very little. And then this, of course, is much more likely to occur. None of this, by the way, is me describing how the studies that I did with Dr. Credenda on adding traditional Chinese medicine in the form of acupuncture. When we were at 20%, we added acupuncture and we got it up to 30%. That was a big, 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 big deal back in the early 2000s. And I should put that over here, an acupuncture thing there. Are there other options? Yes, but we're not going to go into them. These are some of the treatment options. We're not going to go into the menstrual cycle. We just don't have time. But as I was describing, the pituitary is where the follicle stimulating hormone is. It'll take a preantral to become an antral follicle. That follicle stimulating hormone is inhibited when the estrogen gets high, shuts off the follicle stimulating hormone. The estrogen keeps getting higher and higher. And then finally, that triggers LH secretion, which allows for ovulation and corpolutea formation. This is my favorite slide of all. It tells you everything about everything from the hormones. Again, this is not a lecture on that. So here are just some types of treatments. Ovulation induction with Clomid or letrozole. These are oral medications. And the whole goal is to get somebody to ovulate. And the way I talk to patients about that is if I'm in Colorado Springs and I want to go to Denver, I can walk there. And so this is like walking to Denver. I'll get there eventually, maybe, a week or two. Intrauterine insemination is where we concentrate the sperm and put it inside the uterus. So we get past the cervical block. So normally you put 100 million sperm here in nature, 100,000 will get here, but with an IUI, I'll put in a couple of million here. And of course, more sperm, more chance of meeting an egg. So I call it a bicycle ride to Denver. And then finally with IVF, which was asked about before, you basically use a vaginal ultrasound. You stimulate the ovaries to grow instead of just one follicle. Since 1,000 are available, you grow 10, 15, 100 follicles. And so in that one menstrual cycle, instead of getting just one egg out, you may get 10, 20, 30, 40, 50, up to 100. And that's like a jet plane, which is a 20-minute ride from Colorado Springs to Denver. We're not going to go through the fees. Other treatments, donor eggs and IVF. Well, basically, you have a young woman who's donating her eggs to a couple, and with the help of the doctor, we gets a baby. The other option is donor sperm. So this woman either has a partner who has no sperm or doesn't have a partner. And lesbian couples are a great example. And we put the sperm inside the female with the help of the doctor, we get a baby. And then in some situations, we actually use the womb of a woman, the eggs of the mother, create the embryos with the sperm. We fertilize the eggs of the mother, the biologic mother, and then we take that embryo with the help of the doctor, put it inside the uterus of another woman, and we get a baby. And this is that lesbian couple I was telling you about, and this is just another. Now, so for example, that's a lesbian couple, but what about two gay men? Well, they can provide the sperm either individually, or one can provide the sperm for one cycle, one can provide the sperm for another cycle. We do not mix them together and let God choose. That's not a good plan for the baby because the baby doesn't know the father. And we then take the eggs from a donor, use the uterus of a gestational carrier and one of the sperm from the men. With the help of the doctor, we create a baby. This is what I wanted to rush to because we're kind of only have about a half an hour left. And by no shape or means or anything is this any definitive guide. You know, Machiocho's textbook is a great guide. The American Board of Oriental Reproductive Medicine is a great forum. The doctoral program at Yosan University, if this is an area of fertility that you're interested in, there's probably no finer program in the world. I'm not just saying that because I'm there, because it really is true. So in traditional Chinese medicine, there's the concept of yin and yang, and yin represents the feminine, cooling and nourishing, whereas the yang represents the masculine, warming and activating aspects. You understand qi flow, the importance of qi as a vital life energy. Jing essence is considered the fundamental substance that provides the foundation for reproductive health and longevity. And you use organ systems, we use organs, you guys use organ systems to explain like pathologies and understand diseases. So that's just the way fertility wise, we can see that if we don't have a good balance, we don't have good qi flow, if there's an aspect of the Jing essence that's problematic, and then we put it all together into a system. Let's see. Yeah, okay, yes, this is what I did here. Sorry, I have to so the way I'm doing this is I'm giving you comparators. So in the Western medicine, what I want to do is map the Western medicine mechanisms to TCM diagnosis and a syndrome framework. We're going to focus on ovarian reserve ovulation, etc. So when we're looking in Western medicine at a fertility aspect, we look at anti-Müllerian hormone, we look at antral follicle count, FSH, are the granulosa cells functioning, and we actually now look at mitochondrial aging as a thing, where in TCM, you will look at kidney yin, and then jing, sorry, and then yin deficiency, yang deficiency, and blood deficiency. And the correlates are that when there's a declining reserve of eggs, the jing and the yin are depleted. And when there's poor maturation, there's a yang deficiency. By the way, by no shape or form, and anybody can comment that I'm full of crap, but this is my best understanding of a correlate. In terms of ovulation, we look at the GnRH activity, the pulsatility, the LH surge, progesterone has to rise. There's a thing called the luteal unruptured follicle syndrome, which I mentioned. Whereas in terms of ovulation, you look at yang transformation, liver qi flow, and qi stagnation. So the best correlate that I can have is that ovulation is like yang activation, plus a smooth liver qi, and luteinized unruptured follicle, meaning it's just not doing it, is that you have qi stagnation. Endometrium. The endometrium has to want to have that embryo to implant. We look at progesterone, we look at the receptors, we look at vascularity. We have tests called the endometrial receptivity assay. In TCM, you look at yin nourishment, the estrogen juicy part, blood stasis, spleen qi deficiency. And the correlate for me is that the receptivity is really plus yin plus blood plus unobstructed qi and blood flow. So that's kind of just a crosstalk, as it were. For male factor, we measure the count, the motility, oxidative stress. So antioxidants play a huge role in male fertility. In TCM, we look at kidney yang deficiency, kidney jing deficiency, damp heat, blood stasis. And the correlate for me, when you're looking at sperm quality, is jing and yang and absence of damp heat. That's just a thought. In the menstrual cycle, we look at the follicular phase, ovulatory luteal phase, and the feedback loops. In traditional Chinese medicine, you look at yin yang and yang yin transitions, as well as liver qi regulation. So the correlate for us is a nice cycle regularity. For you is a harmonious yin yang transition. In the disease syndrome of polycystic ovarian syndrome, and again, you're going to have all of these slides, we look at excess hair, hyperandrogenism, insulin resistance, anovulation, follicular arrest. We don't ovulate. In TCM, we look at phlegm damp stagnation, qi stagnation. I'm sorry, phlegm damp and qi stagnation. We look at kidney deficiency. Kidneys in traditional Chinese medicine play a huge role in reproduction. So the correlate for us is, we call it PCOS, you call it phlegm damp and qi stagnation and kidney deficiency as causative of this syndrome. The nice thing about PCOS is we have one definition, but in reality, traditional Chinese medicine have multiple ways of looking at that syndrome. Endometriosis, for us, it's about inflammation, immune dysfunction, progesterone resistance, adhesions. In traditional Chinese medicine, we're looking at blood stasis, cold in the uterus. You'll see most of the A-board members will always tell our patients, don't wear clothes that reveal your belly because you don't want a cold uterus. It's not a great place for babies to grow. Or in qi stagnation. So the correlation is, for us, we call it endometriosis. For you, blood stasis and qi stagnations plus cold in the uterus. Stress for us plays a huge role, however, not a measurable one. Stress hormone production is correlated, or heavy stress person is correlated with miscarriages. So that's infecundity and not infertility. There has been a study looking at spinal cord stress, spinal fluid in the spinal cord, and that better correlates to infertility, but that's one study was a one and done. I don't know what happened to it. Never went anywhere. But for Western, we think of cortisol dysregulation, and that in turn suppresses the central axis of control, which is the hypothalamus, and it reduces the gonadotropin-releasing hormone secretion. Stress in a traditional Chinese medicine point of view is liver qi stagnation or heart-kidney disharmony. And you know that there's a meridian that goes from the heart to the uterus. That's very important. And the correlation is, for us, we call it stress, you call it disrupted qi flow affecting fertility. In IVF, we try to figure out why things work or don't work, and we do integrate traditional Chinese medicine. So for us, we look at the ovarian response, the embryo quality, receptivity, and the live birth rate. And what we have found is by adding traditional Chinese medicine in the form of acupuncture, improves blood flow, automatic balance, it modulates stress, and it actually improves the efficiency of the ovarian response. I believe we don't have enough data, but it can improve embryo quality because our outcomes are 10 to 14% worldwide. More babies are born when we add acupuncture. So there has to be both a quantity and a quality. So one way of looking at the improvements that traditional Chinese medicine have on IVF is that you guys are regulating qi and nourishing the yin and the blood. All right. So this is a summary. These are some references. Now, this is extra credit. I love epigenetics, which is epi means on top of genetics. Basically, it's how the environment can change the expression of your genes, not change the quantity of the gene or the gene structure itself. And what we have come to realize is, let's use smoking as an example. We can, that of course influences the first generation, the woman, but if the female, it actually influences the female growing inside the womb, and influences the reproductive cells for this little baby's child. So smoking affects the child and the grandchild, so first, second, third generation or more. One of the things that this is a study looking at the model of holistic and long-term effect of traditional Chinese prescriptions on the patterns of epigenetic markers. So they use markers to see if you can see here that here's a morbid phenotype. You add traditional Chinese medicine, you get a healthy phenotype on these gene maps. So if you think you're not influencing the expression of genes and you're simply moving what you call qi or breaking a stagnation, etc., you're actually influencing generations. A team in Korea found that stimulating specific acupuncture points associated with neurostimulation and Parkinson's disease changed the expression of over 800 genes. So this is where doctoral programs where you're doing research, this is where ABORM, where you're doing research and reading and presenting, keep really looking at the newest Chinese literature on, they're diving very deeply into how your medicine, this was looking at over 3,200 medicinal herbs. Histones are the modifying enzymes for the expression of epigenetic changes. So it's amazing. Now, just like in traditional and allopathic medicine, there are some treatments that have been associated with kidney failure and urinary tract cancers, etc. So again, I just only throw that in because there is no pure good or pure bad. There's always a little bit of both. So I just kind of keep us humble. Prenatal Jing, so basically at conception, the prenatal Jing is passed to the fetus. This Jing, together with the energy from the kidney, nourishes the fetus during pregnancy. It determines the basic constitution, strength, and vitality. It is fixed in quantity, determined at birth, and it cannot be added to, only conserved. So part of your job is to conserve. The way to conserve Jing is by striving for balance in all of life's activities, diet, work, stress, sexual activity, irregularity, or excess waste, prenatal Jing. And so let me, if I can go back here. So think of genetics, your chromosomes, as a pen that can't be erased, whereas epigenetics is a pencil that can be erased and corrected. So postnatal Jing, the child begins eating, drinking, and breathing. This is the environment, epigenetics. Lung, spleen, stomach then begin functioning to extract the refined qi from the food and drink it consumes, and air it breathes. This Jing is a complex essence that's thus refined and extracted, and it depends on the function of the stomach and spleen. Jing, translated as essence, is a very precious substance which should be guarded and not wasted. That's a good philosophy about life. Can acupuncture and herbs impact egg availability and quality? This is what I want all of you to start thinking about, this is from a paper about this topic, um, really start thinking there are qualitative ways you can help us, Western physicians, get better outcomes. The data are now there. You just have to bring it from China to here. Can acupuncture and herbs impact the microenvironment? This is where I believe strongly that the acupuncture is helping, is in that, remember, those follicles are in the body for 20, 30 years unmolested, supposedly, but of course they're molested by the toxins and by poor nutrition and by alcohol, tobacco, drugs. What if with herbs and acupuncture you could improve that microenvironment around the follicle, the egg house, and then that in turn will help make for a better egg, a better embryo, a better baby, a better generation. Stuff to think about. Here's a paper where the cumulus and that follicular flow are critical for oocyte health. So from Western medicine, we know it's important. From a traditional Chinese medicine, I know you could do something about it. This is just looking at a food study and how it impacted the embryo itself. And so even a low protein diet and undernutrition have all been shown to influence, again, not the genetics, the epigenetic changes that influence the quality and quantity of eggs that were produced. This is, people ask, what can traditional Chinese medicine do for sperm production? Quite frankly, I don't even remember where I found this resource, but I don't know if you're trained in this, but it just was for your own information. You can kind of look through all of that. The key for me is that after all this science and medicine and background, this journey is extraordinarily filled with grief, stress, and a sense of loss. And you, amongst any practitioners, because of your nurturing acupuncture clinics, because of the time you spent with the patients, because of your intense understanding of their families and the universe in which they live, you have a unique opportunity to influence their outcomes both for one generation or three generations. And just so you know, and this is horrible statistic, over 50% of those couples who did IVF and got a baby divorce because of the stress associated with the whole process. So I rely on you as colleagues to really provide that nurturing side of what I, in my practice, really don't have the time to do. But what do the patients think about this? Well, the patients, we're going to breach two worlds, and it can only be a good thing. It's 1 + 1 = 3. The language, I've said that we really need to do everything possible so that we talk to each other. And I'll say menstruation issues, and you'll say yin yang transition or yang yin transition issues, but we still have to be talking about the same human being. We need a more holistic approach. We just do constantly. And of course, we can't forget that the individual is what matters. There is no such thing as a 10% pregnancy rate. Patients are either pregnant, 100%, or not pregnant, 0. So does acupuncture improve my chances of getting pregnant? How much? And I said 14% worldwide. But what I'm talking about are populations of folks, not the individual. The individual in front of you can benefit from acupuncture because it's an N of 1. They'll either be pregnant or not, and you'll either help or not. Don't forget that, because we get tied up in statistics. Now, we have about 15 minutes left, and what I'm going to do is introduce you to 14 women. I'm not going to discuss how to manage them, but these are typical patient scenarios walking in the door. 29-year-old single female, her BMI is 20. She wants to freeze eggs. What's the plan? Is it different than a 42-year-old single female BMI 20 who wants to freeze eggs? In the prior one, is the process of getting eggs in this woman different if she were a virgin? The answer is absolutely, because we have to stick a probe in the vagina. In this one, is it different because she's 42? Absolutely, because she has fewer eggs available, needs more medications, needs more cycles. What if she had a total abdominal hysterectomy? Can we still get her eggs? Of course we can, because a total abdominal hysterectomy does not take the ovaries. So she has ovaries, but no uterus or fallopian tubes. What about this one? 29-year-old single woman, BMI now of 40 and wants to freeze eggs. Does it change how I manage her? Absolutely. She has a harder chance of getting pregnant and keeping pregnant. Not that she wants that now, but it does influence the medication route because typically a young woman, high BMI, has a concurrent diagnosis of PCOS. And those patients have a really high risk of ovarian hyperstimulation, which is a rare effect of the body's response to elevated estrogen levels. What about this young lady? She's 42. She has a BMI of 40, wants to freeze eggs. Yes, she can, but what other options may you want to offer her? So, for example, she may freeze her eggs, and the likelihood of those making a baby is only around 10 or 20%. But if she uses a donor egg, not that I would recommend it unless she asked, then she has a 60 or 70% chance of having a baby because she's depleted the egg number, but also the quality of those eggs has been reduced. What about this fanciful lady? It's my trick question that gets every single OBGYN and every single reproductive endocrinologist gives me the wrong answer. She is a 35-year-old woman, G6P0050, and she wants a baby. Don't look at the bottom half. What is the first test you would do for this woman? Or what is the first discussion you would have for this woman? I'll give you a hint. 6 pregnancies, 5 outcomes. She's currently pregnant. And they all start working about infertility and all this other stuff, and they don't see the obvious is she's currently pregnant, but has had 5 miscarriages. And so you ask a second question, which is her partner, whom she's had 5 miscarriages with, has impregnated many, 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 many women, and all of them have had miscarriages. So should I work up the female for miscarriages, or should I look at the male? Fascinating. This is a 41-year-old woman, G3P3. She's had 3 pregnancies, 3 beautiful babies, had her tubes tied. 20 years later, she meets a gym instructor and wants to have a baby with him. And he wants a baby that's his. And what's the plan? Well, you could try reversing the tubal ligation, they can have sex, and her chance of getting pregnant is about 1% over 2 years. Or you could do IVF, and she'll have about a 40% chance of pregnancy if she does 2 or 3 IVF cycles. So very different, still using her eggs, but not using a repaired tube. What about this lady, 43 years old, BMI 29? She's failed 3 IVF cycles with her own eggs. What do you do? Most likely, donor egg, because the age is telling you she has very few eggs. The age is telling you she has many more abnormal eggs than normal eggs. What do you do? An LGBTQ couple wants reciprocal IVF with a 37-year-old partner. So she's 37, she's 19. Whose egg should we use? The 19-year-old, of course, because uteri don't age. So you could use either uterus, but the eggs of this woman is about 5 times more potent than the eggs of this woman. Trans male, what do we do? What options do we have before she female transitions to the male? Well, save the eggs. We do egg freezing, and when this male or this person, trans male, wants a baby, we fertilize the eggs and put them in his uterus or her, yeah, his uterus. Happens all the time. 17-year-old in a serious relationship, recently diagnosed with ovarian cancer. Her oncologist referred her to you. What do we do? Egg freezing immediately. That day, we start the process. Turns out that you can start the process any day of the menstrual cycle. What if she were married? Hell, with freezing eggs, I'd freeze embryos because embryos are 10 times more likely to make a baby than a frozen egg statistically because we don't know if it'll fertilize, we don't know if it'll grow. 37-year-old married black female, two beautiful babies, new partner, history of fibroids. Now we're looking at a mechanical possible reason why now, 20 years later, she may not be able to carry. So now the uterus becomes a huge, huge, huge question mark. 29-year-old woman who has unicornuate uterus wants a baby. She's failed 6 IUIs. Unicornuate means the uterus usually has two tubes. The two tubes come together. So you have two tubes. The tubes come together, and then the lining between the tube degenerates and makes a uterus. So you have a normal shaped uterus. In a unicornuate, it doesn't. So you only have one half of the uterus develop. Well, she can absolutely get pregnant with IVF or IUI, but she has to understand she may have 15 miscarriages in order to grow the uterus to the size to hold a baby. You have to have that discussion. Finally, I think this 40-year-old BMI of 50, self-report, because she won't go on a scale. She has had surgeries, 3 of them. She has sleep apnea, diabetes type 2, hypertension. She's bipolar. She's had 17 pregnancies, 1 live birth, 16 miscarriage, and wants a baby. What do you do? Hell if I know. I mean, I mean, I'm kidding, but these are real people, and you just have to manage them. And there's a lot of ways to manage them. So anyway, that's the talk. I do run the IVF Academy, the clinical school. It's a training program for physicians and nurse practitioners to become reproductive endocrinologists in our field because we are now to do reproductive endocrinology work. And I love training acupuncturists in the DOM program and in the ABORM talks I give in conferences. So that's me, and let's just go to here. Practical takeaways. Establish a referral pathway. Find out where your reproductive endocrinologist eats lunch. Go over and say hi. Find out if he has a conference. Go to the office. Say hi if you want to work in fertility. Coordinate the care. Always communicate. Send your doctors, your referrals, information about what you're doing to their patients and you want them to send what they're doing to your patients. Provide lots of educational material. It's always a great idea. If you can conduct joint consultations, God bless you. One of the unique things at Yosan is one of our doctors, her name is Dr. Agnieszka. She has an REI program, an integrated REI program. So in the doctoral program, you can actually work in an integrated clinic. And then, of course, participate in research. Please come to our symposium. There's all kinds of great speakers, amazing docs, all kinds from Western to traditional Chinese medicine. We have lots of sponsors, which Robert was mentioning. And in conclusion, I think integrating Western reproductive endocrinology and traditional Chinese medicines, patients can unlock the full potential of fertility care. It's one medicine. The collaborative approach addresses the holistic needs of the individual, combining cutting-edge medical technology, allopathic, with time-honored natural therapies, traditional Chinese medicine, and we can empower individuals on a path to parenthood. That's what matters, fostering harmony between modern medicine and ancient wisdom. Now, for fun, write this down, or you'll see it. Either go online and take this test and see if how well you do. And if you'd like, I'd love for you to send the results to me. It's a national test, standardized test for fertility knowledge. That's my name. That's my personal email. That's my personal cell phone. Again, I kind of prefer emails. I'm not a big texter. If you have questions about patients, and first and foremost, don't give me the name of the patients, of course, but or you just simply have questions. Anyway, this is my little chart. I think you should cut it out of your PDF. Tell me if it helps. I apologize. There is some spelling mistakes in there. I apologize. I noticed them later. But I hope this was helpful, and I'm open for questions. I'll leave that up just for fun.
I have a question right away, Dr. Mag.
Yes.
Since there were a number of case studies where BMI may have been a factor or not, there's a stat, and I just don't remember the number, and you will immediately, that I found fascinating where, and I think it's important in Chinese medicine and empowerment of our patients, there's no ideal BMI or weight that improves fertility outcomes. But you mentioned that there is a percentage of weight loss, no matter where the patient starts, that dramatically affects fertility. And I thought maybe you could talk about that.
Absolutely. And it's an easy number. You're 300 pounds, you lose 10%, which is 30 pounds. Your fertility will resume. You do not have to go from 300 pounds to your ideal weight of 129 pounds. If you can get a 10% weight loss, and by the way, it ranges from 5 to 15, but let's use 10, you will see in females a significant improvement, especially in ovulatory infertility. They'll start ovulating and get pregnant. I ran two clinics in my office. One was a Institute for Sustained Health, which was about PCOS management, and the other one was a fertility clinic. And I would send my patients from the fertility clinic to the Institute for Sustained Health. 15 to 30% of them never came back to the fertility clinic because they got pregnant. That's number one. Number two, women obesity has half the impact of men's obesity. And the main reason, it's really simple, is that estrogen is produced by two organ systems. One is the ovary and the other is fat. So men who are obese produce excess amounts of estrogen, which in turn reduces testosterone secretion, which of course affects their libido, etc., but it also reduces sperm production. So losing weight in the male is more important, but as important. Other questions?
There is another question from Michelle, and I'm just going to bring Michelle up. Michelle, I'm allowing you to talk if you notice that. If you want to ask your question directly, that'd be great.
Okay, hi.
Hi.
I see all women right now, but I always ask about their partners, and I just wanted to clarify if I heard the percentage correct. The percentage of male fertility uh, factor in infertile couples that you may see.
Let me reiterate it because it's confusing what I said. If you look at all of infertility, 40% of infertility is exclusively a female factor, 40% is exclusively a male factor, and 20% is both male and female. So it's a 50-50 split. However, in my practice, as an infertility specialist, the female has gone through family practice, OBGYNs to get to me, whereas the male is being dragged in by the wife. He's never seen any. So in that circumstance, there's a bias because I have a subset of the population of women who've already been treated by OBGYNs or are pregnant. So I get a smaller number of infertile females to males, so 60-40. So more males when they get to me as a subspecialist will be the cause of the issue. but I don't point fingers. What are the problems? How do we manage it? Let's go. That's how I do it. Does that make sense, Michelle?
Yes, because it was a
Good.
bit alarming what you first said, but I get it now. Thank you.
Yeah, it's always the guy's
Not
fault.
surprising, honestly, but yeah, that's the first time I heard that. So thank you.
Yeah, you got to get the guys involved. It's so hard. Even you can't
Absolutely.
get them to do acupuncture, you can't get them to do herbs, you can't get them to do, you might get them to get a massage, but it has nothing to do with fertility. But it's just really, really, really hard to. So that's why modeling, good food choices, reduction in toxins like alcohol, tobacco, drugs, making sure you have them sleep 8 hours, not just 2 or 3 or 6 like me. You make sure they're moving. You make sure you're walking at least 10 or 15 minutes a day, hand in hand, talking about life or feeling life go connection. All of those things are critical. To help the guy and maybe get him a nice men's multivitamin. They should also take folic acid, vitamin E, vitamin D3. All Americans are deficient in D3. Don't kid yourself. I used to test, don't even bother. Everybody's deficient. So make sure they're taking, depending on the nomenclature, either 5,000 units or 125 micrograms of vitamin D3 with K2. Um, CoQ10 is absolutely amazing for any type of fertility issue in health. Many women don't know this, but they are undermethylators or they have MTHFR. And so making sure that whatever B complex they have or any B vitamin they take is methylated. Do not give unmethylated medicine, vitamins, or nutraceuticals because it actually works the opposite. It steals the body's methylation and causes more problems. When you give a quote folic acid supplement, when you're really thinking you're giving methyl groups, you're actually taking them away if the folic acid is not tetrahydrofolate. Same thing with methylated cyanocobalamin. As you want to make sure that they're methylated. D, E, C, these are any kind of antioxidants are very helpful. Any kind of antioxidants are extremely helpful for the male. Folic acid for the male is also important and absolutely for any pregnant women. Um, there's a trick out there I use for women who are older and who are have lower ovarian reserve. There is a amino acid complex called Serovital, Serovital. It's a supplement. You can get it online or you can get it at Costco. And what it does is it causes a transient 600 to 700% increase in endogenous growth hormone. And in older women, that is a critical component of oocyte recruitment, maturation, and fecundity. So you can get them Vital. It's inexpensive. That's an adjuvant. You can add that on. It's a growth hormone secretagogue. It's not growth hormone. They won't get taller or anything else like that. Um, I'm quickly running through lifestyle things as best I can. Any other? We fish them with cupping first. We fish them in with. Oh, you fish the men in with cupping first?
I think that's what JC meant. I think that's what
Does the men like that? Cupping? I don't know. Can you speak to other ways to increase egg quality with complementary foods? I think I kind of threw those all out there. Um, and lifestyle, avoid alcohol, tobacco, drugs, 8 hours of sleep, meditation or time of thinking and centering, water, hydration. Everybody's dehydrated. Not good for sperm. It's not good for the female menstrual cycle, and it's not good for pregnancy. So hydration is critical. Electrolytes are wonderful, especially without sugar. Um, okay. Anything else? There you go, drinking some water,
taking
Ra.
your guidance there.
Okay.
What's really
Any-
clear is how much more there is for you to share, Dr. Meg. And I know of an upcoming event that is a good place to learn even more at. And I think if you scroll up in the chat, you're going to see a coupon code that is still good for this year, CSOMA 25.
Oh
Don't
yes,
forget,
our
you're
Integrative Reproductive Medicine Symposium.
so Rob, do
Yahoo!
you want to talk about that at all? Since
Yeah,
that
it's
you're
actually it's like 40% off. So
It
Wow.
it's a
really is huge. I just bought my tickets. It's
oh
a
my
huge
goodness.
discount, everyone.
yeah.
Go do it now. It's a really huge discount.
That is a big discount, and you can get more of this and go deeper in this learning and maybe begin your ABORM process. And there is an ABORM member in here. Tara Greenberg is. So way to represent
Yes.
Tara. It's so nice that you're here.
Good
Um,
to see
so yeah, so thank you, Dr. Meg. I think this is just hopefully, skimming the surface of how much there is to share and learn in this discipline of medicine, and a place where we can make a huge difference in patients don't know of us for many things. And pain and fertility are two places where patients will actively seek us out because of how much good work is being done, right? So
Well, I'm grateful for the opportunity. Thank you so much. Thank you, Robert. Thank you, Rob. Thank you, Julie. Thank you, Kim. Thanks to everybody for joining because it's always fun to have an audience that asks questions. And I hope to see you at the meeting. I'm looking forward to it.
fabulous. All right, everyone. Thanks for joining the CSOMA community tonight and our 2026 webinar series. We will see you here again March 10th, because it's just 28 days in this month. March 10th is our next speaker. Learn all about taxes. You won't know how important that is, how much money you're going to save till you show up for that one. Thank you so much, Dr. Mag.
Bye.
Thank you.
Bye.
Thank you, President Julie Tran. Thank you, Rob Hoffman, board member, doing such a great job at Yosan, and Kim Newman, the longest running CSOMA person, keeping us going here. Thanks, everyone. Happy Tuesday. Stay safe out there. Have a
Bye.
good night. And thanks for being here.